We have new cabinet secretaries, 19 of them. Sindio?
19 eh?
19.
Ni 19. Lakini kuna wengine but no.
Those two are being vetted.
And the one today. Kuna space bado imebaki ya tourism.
Kuna space ya tourism ambayo needs to be filled.
Then kuna wawili.
Then there's the cabinet secretary nominee for East African Community and Regional Development, who is yet to be vetted, and the AG, who is also yet to be vetted. All right, but one who was vetted and passed with flying colors according to the Committee on Appointments and was sworn in yesterday is the Cabinet Secretary for Health. What's her name?
Deborah. It's written Deborah. Deborah Mlongo Barasa.
Dr. Deborah Barasa is the new Cabinet Secretary for Health.
Yes.
She took her oath of office yesterday and promised to conscientiously work to deliver for this. This is our second Health Friday conversation today. We want to say, so how is her entry gonna look like? Looking like as she got into office yesterday. Dr. Theuri, the CEO of the Kenya Healthcare Federation, is our guest. Dr. Good morning.
Good morning.
How are you?
I'm very well.
Good to have you here again.
Cold morning.
It is, eh?
It's chilly. You know, you say cold. It's like when they're gonna breeze. This thing is chilly.
Is it still misty out there?
Yeah, it's quite misty as well.
Hiya.
Yes. Yeah.
This weather app is saying that it's cloudy.
No, it's quite misty.
Okay.
Yeah.
It's a cloudy plus misty.
Telling us something. Because it seems to be on Thursday, Mandamano Day, and in a kuja, and then then Friday, then in a descend in a cloud, so mist. So hiyo sasa, I mean this,
iko maneno.
Tunaambiwa
Nairobians mkae nyumbani.
Iko maneno hapa. Iko maneno. City, welcome Dr. Theuri with the day's proverb.
Yes. This is our final proverb from the Republic of Botswana. Okay? Dr. I'd like to ask you a question.
Yes.
Two, okay?
Yeah.
This is one of the pitfalls of being a doctor. Unauliza maswali mingi. One, okay? Our proverbs for this week, last week, and the week which is to follow are from landlocked African countries. Please name one landlocked African country. Now,
Central African Republic.
Good man. He didn't even let me get to don't mention Uganda. He just went Central African Republic. Pop. Correct, it is. Okay, now question number 2. This country we live in is called Kenya.
Yes.
So the person who is a citizen, now mwenyeji, what do you call him? A
Kenyan.
And when there are many?
Kenyans.
Okay, now.
And the language?
Kenyanese. It is Kenyanese because we will mix languages when we speak. That is we will mix it. Depending on who you're talking to, there'll be English, there's Kiswahili, and then there's mother tongue thrown in, then there's Sheng thrown in.
And then Tulu.
All in. Now, so in the country of Botswana, would you have an idea of one Botswanan is called?
Would I don't know.
Okay, then, if there are many, what do you call them?
I'd possibly go with Botswanans, I don't know.
Do not worry. Even I didn't know before I looked it up. One, another Motswana.
Motswana.
Yes, many Botswana. Batua.
Botswana.
Yes.
Botswana. And Botswana.
Yes.
Motswana.
Yes. One is
Motswana.
Do I get a chance to ask you?
Yes.
The citizens of Seychelles.
Yes.
What are they called?
Seychellois.
She got it.
Try another one.
Good one.
Good one, eh? Asante sana.
Tupatie proverb.
Proverb nikupatia, okay? Famine hides under the granary.
Famine hides under the granary.
Good one. This is from Botswana.
It's from Botswana, yes.
What do you think?
What do I think? Famine hides under the granary.
Famine.
Oh, famine.
Yes.
Famine. Famine.
Hides under the granary.
Yes.
That's a good one. Ukame. Hiyo tufikirie tukiendelea.
Sawa. Wewe ni mgeni.
Welcome.
Kwa hivyo, we'll come back to you.
For sure.
Just one is quite a bit cryptic. Eh?
Yeah.
It is, yes.
Famine hides under the
The
granary.
granary, yes.
Okay. Anyway, first of all, what is the Kenya Healthcare Federation?
Kenya Healthcare Federation is the largest non-state actor in health, with over 260 business member organizations spanning the entire value chain. So what we do on a day-to-day basis is taking care of our members, allowing for an enabled business environment, and ensuring that healthcare is provided to Kenyans in an affordable, efficient, and available manner. You could have healthcare that is affordable but unavailable, and our work is to ensure that all those three converge at the point where the Kenya needs it. We are quite keen on optimizing the relationship between those who seek care and those who provide it, because I believe healthcare should seek to optimize that relationship, and everything else is just supportive of it.
260 member organizations?
Yes.
Those are many.
Those are
All of them only in the healthcare space?
Healthcare space. You will
What
find
do they do?
You'll find companies that have interest in health will also join, including banks that are interested in banking the sector, fintech companies that are providing technology solutions and financial services as well. So it is quite the cocktail, if you were to ask me. What we do is something I struggle answering, because if there's a crisis, it will land on my desk. If there's celebrations, they also land on my desk. So it is basically everything.
So let me just try and guess. There are various doctor associations, for example.
For sure, we
right?
have professional associations.
So those professional associations,
Yes.
each of them then becomes a member of the
KHF,
Healthcare
yeah.
Federation.
Yeah.
The service providers,
Yes, we have hospital associations.
they have hospital associations.
Exactly.
Rural Hospital Association,
Kenya Association of Private Hospitals,
yes.
Christian Health Association of Kenya, KCCB, SUPKEM,
What is KCCB?
Kenya Conference of Catholic Bishops. Yeah, that's a Catholic church basically. They're more known for education, but they also have
They do have hospitals.
many
they
hospitals.
do have hospitals.
Yep.
The SUPKEM, that's the Muslims,
Yeah.
the Hindus as well. So it's quite the cocktail, if you were to ask me.
Nurses,
Nurses as well, the nurses associations,
lab techs, technicians.
all of them.
So all of them in all those associations
Yes.
then all come under the federation.
Yes.
Okay.
Yeah.
Right. So you when they have issues, there are some issues that they can advocate directly.
Yes.
And there are issues that are then cross-cutting that come to you.
Yeah.
I'm sure that an issue of universal health coverage
Is
and the rollout
familiar,
of
is
universal
familiar.
health coverage comes under you then.
Yeah, for sure.
Right?
Yeah.
And making sure that we have access, like you said, affordable, accessible healthcare
Yeah.
across the board also comes under you.
Yes.
Do you get pulled into thinking private and public? Because I can imagine that you have all these faith-based healthcare providers who are the bulk of healthcare providers in the country. You've got private healthcare providers. Then government healthcare providers are not your members. It's only the people who work that are your members. So do you find yourselves then just advocating for private health?
I will put some statistics as per the 2024 economic survey that was released, I think, in Q2 of this year. That's a calendar year. 54% of the care in the country is with non-state actors. 46% being private, that is for profit and not for profit, and then 8% being faith-based and CSOs.
So that again, 8%
being
is faith-based.
faith-based, and the CSOs at community level. The rest is now with government. We have about 100,273 beds as per that report in the country. So you can do the math just to disaggregate those figures. The public side tends to have a higher bed occupancy rate than the private sector, but the private sector will have a higher per bed, per patient, per unit time turnover. So the number of people who are going through a bed is higher in the private sector.
Okay.
You ask whether we advocate for private. What we advocate for is an enabled business environment. That is what we are keen on, for two reasons only. One, Kenyans are not lazy. Kenyans are asking for an opportunity. Give them an opportunity. That's what we advocate for. So we'll advocate for policies, for taxes that allow people to do business. That's what we advocate for. The second thing that we advocate for, like I said, the first one was an enabled business environment, and then the second one was that opportunity to do that business. Most of the businesses that we handle are SMEs, about 80% of them. And out of that, about 62% are owned by women and youth. So these are businesses that just require liquidity to function. So that is currently what is hot on my desk as we speak. We have anywhere between 28 all the way to 60% exposure for some of these businesses to NHIF business, now the Social Health Authority. So if that authority is not well capitalized and funded, then you can begin to see the crisis that we have in the sector, because we are a liquidity business. If you're to just speak the truth of the matter. Unlike education, health has not had the benefit of a unified sector, if I may call it that way. Because if the Minister for Education says schools will open 2 weeks from now, all schools will open 2 weeks from now, our sector has not been able to enjoy that harmony. And I think among the things on the entry for Waziri will be that, to ensure that you have good harmonization in the sector.
Why is there no harmonization?
It's how the sector developed all the way from independence. So we had the public sector taken care of by government, and that developed along one channel, and then it reached a point where there was a need in the early 90s for alternative care, and that's how now the non-state actors came into play. And if you look even at the budgeting, traditionally, we've not, as a sector, received a good portion of, in terms of percentage, compared to other sectors like education. Yet health is a public good. I think it is the only public good that is yet to be, let me say, sorted or taken up fully by government. This time round, there has been quite the conversation on health. The Kenya Kwanza government has talked about health, up to and including when the cabinet was being dissolved. His Excellency the President talked about his health agenda. And even yesterday he mentioned the health agenda. So I want to think that it's quite central in his vision. When I look at the physical space we have as a country, I don't think it's going to expand, not at least for the next 3 years. So the people who can build scale and continue to offer and bridge that gap, and in a responsible way, will be non-state actors. So for Waziri, how does she bridge this gap?
How does she look into accommodating and making the business environment conducive for the non-state actors who are playing in this space? I usually have a problem with these issues because I see, like you said, health, education, public good. Education has continued to receive the bulk of the budget.
I think 600 to 700 billion in this.
But if you look at education, the provision of quality education in the public has been going under as private sector rises, right? So more and more people, particularly in basic education and in primary school, are ending up taking their children to some form of private school, whether it's low, middle, or high cost. But they are choosing not to go to a public because the publics are not developed. It's the privates that are developing. And so that has continued to affect now the cost of provision of education for many people into secondary school, where now there's secondary school, there's no, apart from day schools, there's no free education per se, and it becomes very expensive for very many people. You champion access to affordable, accessible health. Now, affordability would obviously, if you're looking at private and public, public would be more affordable if it was more accessible.
Yes.
Public has more beds, like you've just said. More beds in...
Private now has more beds.
Private has now more beds.
Could you just mention the ratio?
54%.
54%.
Yeah.
For 54% of people
bed capacity
going in the country.
In the country.
Yeah.
Is it bed capacity or is it people going to?
Bed capacity.
Okay.
Yeah. Of course, public will enjoy a higher foot flow. Yeah.
Okay. So the higher provision of healthcare in this country is by private.
Yes.
Okay. And only 46%, less than half, are going to public. Who are in this whole conversation about social health authority, there are two elements of the social health authority funds that are public taxpayer funded.
Yes.
The primary and the emergency and critical and chronic illness. Where should this money go?
Where should this money go?
Yes. Should it go to public? Should it go to private?
I think it should go to providing care for Kenyans, and I'm not being political in my answer. The reason I say that is because what is a Kenyan interested in?
Healthcare. Yep.
Now, the reimbursement rate will not change whether you're in public or private. So if I'm a dental surgeon by training, so if I'm supposed to get my teeth cleaned, then that say should cost maybe 5,000 or 2,000, whatever. Then whether I go to public or private, the reimbursement rate remains the same. Government will tend to enjoy some form of subsidy because healthcare, the labor is taken care of. The buildings have already been taken care of. On the other side now, those are cost points for
the private sector.
For the private sector. Now, in terms of employment, if you are to look at the other indirect benefits of having the two sectors go hand in hand, we'll have people employed in both sides. As per the Health Labour Market Assessment report, the private or the non-state actors are employing 7%. The growth in employment has been at 7%, while in the public side has been at 4%. Yeah. So the indirect benefits when it comes to the ecosystem will be derived a little more because of the way money moves in the sector when you come to the private side. I have been a huge champion of a working public side because if the public side works, then automatically the private sector side will work. It goes hand in hand. Yeah. So I don't see that line from where I sit because with our work together with the ministry, that is what we champion for.
Can you explain this to me? When you say if the public sector works, the private sector will work, well, elaborate on this, please.
All right. So, for example, if the facility that is public next to you has commodities, has health workers, it's clean, and you're assured of service when you go there, the non-government facility that is possibly within the same area or enjoying the same catchment area will have to step up, all right, and provide a competitive advantage. And in so doing, we are going to raise the bar for everyone. It's like a rising tide at sea. It will rise with all ship. Yeah.
You know, when you look at health provision, and again, when we talk of the budget, from everything we hear, it's always insufficient. But we in this particular room have a problem whenever we hear of the word insufficiency, whether it's with reference to the county government or the national government. The monies that are available, we never quite see the totality or the comprehensive nature in which that particular money is utilized for you to say it is insufficient. Because the moment the audit queries with regards to expenditure, it means certain things are not clear and some are easily spelled out with clarity. One can't identify, one can't pinpoint what this money was used for. Why do I bring this issue? From everything you've said, the entity that you work for has a clear outline of what it is that they expect. I take the view that because colleagues, schoolmates, classmates, people you know are also at Afya House and they run the various departments in Afya House. So these are conversations you've had.
Yeah, for sure.
Okay?
Yeah.
And I don't think these are conversations you're going to have because you have a new CS. They're conversations you've had. Okay.
Yeah.
Now my question, having had the conversations before, what are the gaps that you have seen? And of these gaps, which ones would you think are the most urgent that would need action on with a new CEO?
Any organization needs three things. It either needs fixing, it either needs optimization, or it either needs growth. The challenge to Waziri now, or the conversation I'd begin to have, would be, of these three things, what is currently taking the lead? Because, of course, they will be at different ratios and proportions for such a big entity like the Ministry of Health. And in my honest opinion, there's a lot of fixing that needs to be done as you're moving towards optimization. And her being a technical person, I think she carries that advantage of understanding how the sector works. The second...
Repeat that statement again, please.
Her being a technical person...
Yes.
Because she's a doctor.
She's a doctor. She has the advantage of knowing how the sector works.
Has she worked in this sector in Kenya?
In the public sector? In earlier years, yes. Recently, from the documents that I have seen in the public space, she's worked in the health system strengthening bit of health, and we are right in the middle of that. So that is a skill that will be required. The other one is she'll be called upon to offer very good leadership that will lead towards culture change. The biggest barrier to trade in Africa is integrity. Will I trust that when CT says he's going to bring me this, will he deliver? Ama niweka pesa kwanza.
Weka pesa nikupe nusu.
Yeah. So that is the biggest barrier to trade in Africa, and that's why companies like Amazon will really struggle in our continent.
So we now have a new Cabinet Secretary for Health, and her name is Dr. Deborah Barasa. She was sworn in yesterday. I assume she's already, if she's not in Afya House now, she must be in one health facility or one department somewhere, but she should be working. The Director General of Health has also been confirmed. Now he's substantively in office, anakalia na yote mawili. Okay? So this sector now is sort of sorted. Higher. So what is it that we should all expect from the Health Ministry? Dr. Theuri, the CEO of the Kenya Healthcare Federation, is our guest. The in-tray for the new Cabinet Secretary for Health, Dr. Deborah Barasa, there's a lot for her to do. So you said one of the things that she will need to work on is to provide good leadership that leads to a culture change at Mafia House. What would this take?
I think once she needs to have a strategy, and that begins by having a good team around her. That's excellent people who will form part of her advisory team. Strategy drives change in structure. So when there are new CEOs anywhere, among the things that are responsible for their success is the structure around them, and structure is made by people. So she will need an excellent senior management team with her as well.
Does she get to pick the senior management team? She doesn't pick the principal secretaries.
She doesn't pick the
The Director General for Health
has
already
recently been
picked.
confirmed.
Okay.
So there are directors as well within the ministry who are in charge of directorates. I mean, what I've observed from patterns in history is that leaders tend to change the senior management. So I would anticipate that would happen as well from where I sit.
Is it a good thing or a bad thing? Or it depends on how it's
It
done?
depends with how you look at it.
Okay.
We're in the season of change. One of the people who, if I were her, I'd have around me someone who's good at change management, because there are various components of change. There is where you're coming from, where you're going to. People need to understand that. And in them understanding that is you need to communicate. And communication happens on the listener's terms. So you can't communicate what is... You'd be happy to communicate what is in your head, but if it's not being understood, then it's...
Let me ask you a question.
Yes.
You say a culture change, which means there's a culture, and which means that culture has to be understood. You can't possibly change something you don't really understand.
Yes.
I mean, and that takes time.
Takes some time.
Yes. Now, within any ministry of the government of Kenya,
Yes.
they are the mandarins. They are those who run the ministry. Yes, I'm talking about officials who run the ministry.
Yeah, for sure.
I have not taken the conversation to what we hear as individuals called cartels. I'm not going there. No, I'm just talking about the people who run it.
Yeah, for sure. Even in our homes, you could be in charge, but you don't run the home.
Even that in charge thing, I'm wondering one. In charge. The person who's in charge, there's clarity as to who's in charge. I don't know why people think there's ambiguity. There's clarity.
There's clarity.
Yes,
Fair enough.
there's
Let's
clarity.
proceed.
Yes. So I'm saying something like the Ministry of Health, an entity like that, and you say we're in a season of change, they would be acutely aware of this.
Yes.
Okay?
Yeah.
It's not often that you find a minister change midstream.
Yes.
And when it happens, as you say, what it forebodes is change. Now, when people get into cocoons of self-preservation, simply because they see and they foresee, and there are those who immediately corral around the leader to ensure that their side of the story is the one which carries weight. This is Kenya.
This is Kenya.
Okay? Now, somebody who has not fully comprehended how that ministry functions, it doesn't matter how well-meaning you are, you will have a huge problem.
I agree with you. The work is there. There's a lot of work to be done. And that's why I began by saying that her leadership will be called upon. And part of any leader in the way you operate are pockets of quietness, where you still your mind and you make the noise go away, so that you're able to have good direction and clarity of where you're going. And that is part of strategy. So she will for sure need that. I think even the PSs that we have are all outsiders from the ministry. They all came from elsewhere, and that tends to be a good thing when you want to institute change, because they bring the freshness of ideas, they bring a new way of thinking, previous learned experiences come into play, and that can also be very, very useful. Actually, today in my morning reading, what I was looking at is when CEOs come in, what tends to happen, and within the first 12 and 14 months and 18 months, and what you find is on average it takes about 3 months for heads to roll, maybe another 8 to 9 months before there are changes in operations, and then by month number 14 is when you begin to see meaningful
to feel the CEO.
Yeah. So, one of the regrets that the same article was saying that these CEOs have is that they tend to miss the people out, not to be people focused. So, I'd be keen to have this conversation with her maybe a year and a half down the line, just to see what her experience has been. But top of my head, we need to change the culture. We are producing excellent documents as a sector. that other countries use to work on and further their healthcare, but we also need to work on these documents and implement them. We've largely been outward facing in terms of how we're operating. Our staff will be in co-creation meetings out of the workstation, and that is a good thing. That's how we are getting to develop the documents. But now there needs to be the next phase,
which is doing.
What
frustrates that doing? Is it the staff that develop the documents that don't want to do? Or is it their bosses who are from elsewhere who keep being changed left, right, and center?
Innately, human beings don't like work, Eric.
Innately, human beings are lazy. That's what
they're
you're
lazy.
saying.
They don't like work. But we have to work for certain things to happen to us. And it is the liking of those things that keeps us at work. So we must change how we're incentivizing the system. So, if I'm out of station for work, then I may get a daily sustenance allowance. Being out there, it's a better environment, maybe. I mean, all those things come into play. My working hours, all those things. So we must change how we're incentivizing our workers at the ministry. Technically, she's also running a level 6 facility there, because I think there is a staff establishment of north of 400 doctors.
Wow.
Drawn from various specialties, of course. So it's a big institution. So looking into how her together with a senior management team will bring in changes to incentivize and lead to the doing is now part of the strategy that she needs to employ.
Do you think she will have the leeway to implement this? Leeway here, I mean political goodwill, right? Because this ministry, just like many other ministries, but also this ministry has very many political tenterhooks.
Yeah.
Right? Those who are appointed politically, those who rise politically, those who have stayed politically, those who represent certain political interests. Do you think she actually has the broom as she gets into office, that this broom can sweep any corner of this room?
I think the answer would be yes.
You think so?
I think the answer would be yes. Okay. There's been a lot of conversation on health. Like I said, it was the only agenda thing that was talked about, or rather, the president has been very consistent on. So the goodwill, from what I see, is there. The changes that we need to see are not from bad
to us.
No, are not from worse to bad. Some of the places actually we are moving from better to best. Some we are moving from good to better. We have very competent people at the ministry. That is given, and like you've said, some of them have risen through the ranks. Others have been introduced externally at various points in the journey. Her work is to now weave all that together and ensure that we have a working machinery there.
So what does she need to do? So, for example, let's just look at the rollout for UHC, which is the most recent example. Laws are passed.
Excellent.
Now it's about implementation. Okay. If we look at how the health ministry under the previous CS worked at that time, so we are hearing messages that are coming from NHIF. You're hearing messages that are coming from the new SHA board. You're hearing messages that are coming from advisors to the president. You're hearing messages that are coming from the ministry itself, the 2 state departments, and then the CS herself. And there was so much confusion. This rollout has been pushed and pushed and pushed. We don't have clarity whether we are registering for SHA or not, whether we are launching SHA or not. It's because communication has just come from various quarters. That means there are various centers of power. The only thing that has changed is the CS.
Yes, and clearly there is no harmonization. And yet this is a service that by its very nature is critical. Not necessary, critical. Yes.
Like I said, she needs a change manager next to her. For sure. Or a change specialist, so that they can walk this journey together. When you look at the changes that have come from NHIF to SHA, there are various components that were being changed. There was legal reform, there was operational reform, there was technology delivery reform, and there was also structural reform through introduction of primary care networks and a referral system. So, what those things can happen concurrently, but at the various phases, there's what is supposed to begin as you build up towards the climax. In my opinion, I think the legal reforms have leapfrogged operational reforms, and that's the conundrum we are in right now. If you've worked in places where you're implementing any system, before you have a go live, it takes quite some effort, yeah.
Yep.
And what she needs to do is to work with the industry. That is, have feedback and have a finger on the pulse, so that she's able to get real-time feedback from both the county governments, because that's her other big constituent, and then on state actors who are us, the Kenya Healthcare Federations of this world. And with that, now she will get very honest feedback and uninterrupted feedback.
Dr. My question is actually,
you asked me what she's supposed to do. I'm telling what she's supposed to do. That's what she's supposed to do. And without those partners on board, it will become very difficult. And you must listen to them, because they're the people who are doing the work. They're the people who are feeling the pinch of a creditor on their door. All right? County governments, we passed the FIF bill. Very soon you're going to see a lot of CCs for health at Senate answering audit queries. The reason is the way the law has been structured is fantastic, but do they have enough people to deliver care at a dispensary? There's maybe 2 or 3 people. They are the people offering care. They're doing the administration work. They have to comply with the Public Procurement and Asset Disposal Act in their work. So there are definitely going to be gaps. All right, they are well-meaning at that level, but the law is a law. So when the Auditor General comes and sees, okay, this was not followed, audit query. All right, so they have to go and answer those things. So what possibly we need to relook in this tab at UHC is what was wrong with operations first. We correct that. We focused on fraud, wastage, and abuse. Excellent. We must seal the leakages, and I think it is the interest of anyone to seal leakages. Yeah. But are we also rewarding good and best practice within the system? Because everyone is being lumped into the same box. If you're all
old, you are eating.
Yeah, you're all thugs. That's what is being said. But that is not the case. We are having facilities that are doing an excellent job. When you look at the quality, is it Quality Health Awards Kenya? Actually, quite a number of public facilities were winning. All right. There's a particular sub-county in Mombasa, Tudor, that collected quite a huge number of these awards. And then that's a good thing. If we were to go to the granular level and look at the way those indices that you look at, you'll find that a lot of good is happening. But you can't balkanize and throw everyone into the same pot. It is happening for this corruption to happen. It's both ways. We have bad providers, but they're not bad in isolation. All right? And our opinion at KHF has always been the bad need to be punished so that there is more for the good people. And on the county government side, they must also look to bolster their collections. And I think that is what FIF, the bill, will also help. Because they don't have any incentive to follow their collectibles. Right now, what happened at NHIF was one day in, I think, was it 2019, they woke up and closed the system that they had. And with it, about 9 billion of providers' money. Right now, government agencies will deduct but not remit to NHIF/SHA.
Yep.
That money is in the tune of 26 to 30 billion.
Jeez.
So that what we are saying is, let these people pay first SHA, And you see, the Act now says they cannot have monies in interest-earning accounts. So there's no incentive to keep the money.
Yep.
So if it reaches 100 million, they release it.
Release it, pay.
Yeah, and they've been doing that. We've led the national engagement with providers with SHA, and what has come out is there was a steady increase in the money that was circulating within the ecosystem. And when the legal reforms came in, of course, because of the uncertainty and people just holding back, there was a decline. And there's now a lot of distress in the sector. And if we are not careful, possibly an imminent collapse may happen if we are not careful. But because of the nature of health services, it will be a hypertensive death.
Okay.
It will kill you slowly.
Let me ask you. On a scale of 1 to 10, 10 being very confident, what's the level of confidence that the health sector has on the new CS? Putting you on the spot, I know.
You're putting me on the spot.
Yes, we are. That's one of the beautiful things about coming to the show.
I'll give it a 7.
Okay.
All right? A 7 being because we'll assign hope first.
So a lot of it is hope.
A lot of it is hope.
Okay.
And
do you think
she
she enjoys the same kind of level of confidence from this is the healthcare sector? Do you think she's enjoying the same from the county governments? Because she must work.
She must work with the county governments. And that relationship has been very sound.
So do you think that the Council of Governors, the county governments, will extend her accord her the same kind of confidence?
I think for them will be a watch and wait approach. That's what I think they will do. I have observed that relationship being very, 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 very dicey and sour over the last few years. They will feel that there's been a top-down approach when it comes to them. So in health system strengthening work, which she has done, relationships are at the middle of it. So I hope that she's able to mend that relationship quite quickly, call upon them because they are her other biggest stakeholder, and just have their buy-in and goodwill. For us, we are saying as non-state actors, we are going to give her the goodwill.
The benefit of doubt.
Not the benefit of doubt.
Goodwill.
Yeah?
Goodwill.
Here we are not. Here we can't have doubt anymore.
Okay. It's goodwill.
She's already been sworn in. There's already a flag in the car that transports her. So we are past doubt now. So we are giving her goodwill. And with this goodwill, what we are saying is we will support her because we are interested in her success. Her success is our success. And we'll do our best to ensure that that happens. I know time is nearly up, but
It is up.
I will add 2 things. One is she should be keen to ensure there's policy stability in the sector, so that when money comes into the sector, both on the public and the private side, it can be predicted how it's going to behave in terms of cost of credit and also tenure of this credit, because we are going to experience dwindling donor funding into the sector. So the conversation of sustainability has to be had, and you cannot have that outside good business acumen.
Okay.
Yeah.
Let's end it there. Dr. Tim Theuri, CEO of the Kenya Healthcare Federation, has been our guest.
This is the Situation Room, the only way to start your day.